Hello, good morning to everybody. Welcome, panelists, welcome, public attending. Thank you very much for joining this webinar. I want to remind you that we are live and through YouTube, and that the event is also being recorded. Okay. My name is Elena Rocher, and I will be in charge of conducting this session during the next, hopefully, 2 hours and a half. I work as RPD and Innovation Technician in Las Naves, which is a municipal foundation of Valencia City Council, whose aim is to promote social and urban innovation, acting as an urban lab to test and validate innovative solutions to improve the lives of people. One of the projects currently ongoing is VALUECARE. This is an innovation action of phase 2020. The aim of this project, as you will see during the webinar, is to provide all the adults with an intervention focused on value-based integrated care and improve the lives not only all the participants, but also the caregivers and the social and medical professionals who work with them. The value-based methodology for integrated care that we are going to define is supported by an ICT solution. Thus, our project joins two key emerging trends in healthcare: integrated care and value-based care, aimed to improve the health of people and outcomes on health. Moreover, pandemics, as you know, have deteriorated chronic conditions. You all know that a decline has been detected in the physical, mental, and emotional health of our older citizens all around Europe. Now, more than ever, there is a need for an integrated approach to care, shifting the focus from a silo-based approach to social and healthcare delivery as a whole pathway. In this context, this webinar aims to raise awareness and increase knowledge of integrated care among various stakeholders at a European level. This is a chance to share the knowledge of experts in the field and learn from experiences of integrated care programs in practice throughout Europe. So this is an approach to learn one from another. So the schedule of the webinar will be like that. We will start with a general introduction about both concepts, integrated care and value-based care. Then the first section of the morning will be devoted to interventions that share knowledge on integrated care, such as a general framework and main theories on it. User's perspective, which is the user perspective of older adults, which are the main target of integrated care. And finally, we will know how digital solutions can support integrated care. Then we will have a short break of 10 minutes, and then we'll come back with the second part of the webinar, where we will learn about the experiences and case studies in the implementation of integrated care in different domains of social and healthcare, and their benefits, of course. So we can learn a lot from all these experiences. So just some practical tips. I ask the panelists to please stick the agreed time so that the public can also raise questions at the end of each of these blocks I have described. And to the public, please feel free to write your questions in the YouTube chat. And please, if it is addressed to one of the panelists, indicate it in the question, okay? Also, we would like to thank to Covenant on Demographic Change, also to our VALUECARE partners that are taking part in this webinar, and also for their support in the communication tasks and for participating, and of course to the rest of the panelists. Okay, and so please, just another practical tip: please, panelists, remind to be muted while you are not presenting. Okay. So we are going to start with the first block of the webinar with Professor Hein Rath. He's a medical doctor, physician of public health and community medicine, epidemiologist. He's currently professor at the Department of Public Health at Erasmus Medical Center in Rotterdam, Netherlands. He's principal researcher in many research projects, such as VALUECARE, which he is our project coordinator. He has produced around almost 200 publications in the last 5 years. And he's honorary member of several scientific networks, consortiums, and committees on his domains of research. Okay? Just Hein cannot stay until the slot for the questions, but if there are any questions for him, you can send them. We can put it in the chat, and we will send them to him by email so he can answer afterwards. Okay? So, Hein, please, you have the floor.
Okay, Elena, thank you very much. Thank you very much for organizing this webinar and for inviting me. I will briefly ValueCare project. This is an Horizon 2020 project with many European countries participating, including Spain, of course, and the city of Valencia. Wait, I will share my screen.
Mm-hmm.
Can you see it like this?
Yes, perfect. Go ahead.
Yeah. So the overall goal of the ValueCare project is to deliver outcome-based integrated care to older people and using large-scale ICT solutions, so internet-based solutions. And the goal is to improve the quality of life of the older people, and also their families are often very much involved in taking care of the older people. And also a goal of the project is to make the European health and social care system more sustainable. So this goal was developed by the European Commission because of the demographic change. So I'm also very happy that the Conference on Demographic Change is involved in this webinar. Europe is facing a big challenge with the demographic change, and the care systems need to innovate to not only to make the care system sustainable, but also to have people have a longer and active life in their own houses with more quality of life. The focus is on the older people and their primary care, their caregivers in the family or in the neighborhood. But the secondary goal is also to make the system more sustainable, and also to make the healthcare professionals and the social care professionals more happy in their work. Because we know that the burden of giving care can be quite high, and there is a risk of burnout or to overburden the healthcare system and also the healthcare professionals. So ValueCare also aims at the healthcare professionals and the social care professionals to improve their job satisfaction and to see how ICT solutions can reduce the work pressure on them. ValueCare aims at older people who may have cognitive impairment, who may have frailty, like a general weakness in the physical area or in the psychological area or in the social area, or older people with multiple chronic health conditions. Those older people are the target group for ValueCare because the European Commission and also we expect that they can benefit from integrated care most and also from ICT solutions. So I told already the sustainability of the health and social care system in Europe was one of the departing points for the European Commission to fund this project. And we also know that big innovations are expected in the field of internet solutions. In this project, it is not the purpose to develop new internet solutions. The purpose is to find the best solutions that are available on the market at this moment and to implement them in the context of integrated care. So the European Commission asked us to do a large-scale implementation and to evaluate these internet solution, ICT solutions at a large scale. So we expect a broad impact of this combination of integrated care with a value-based approach, and I will discuss that later, combined with internet solutions, ICT solutions. So we expect broad impacts not only on the health of the older people, but also on the caregivers in the family or in the neighborhoods. Their mental health and also their burden can be high, and also the well-being of the professional and the social health professionals. We also expect a social impact because of the approach of co-design that will be applied in the VALUECARE project. Co-design meaning that we make the choices in discussion, not only with the professionals, but also in discussion with the older people in the communities. So the aim is to have impact on the organization and process management, to have lower cost and expenditure, and to have better utilization. And in the end, the aim is to have a higher cost effectiveness, reduce cost and better outcome. Here you see the schedule, the scheme of the project. So the first half of the project is a development phase, and the second half of the project is a pilot phase. In VALUECARE, 7 countries will implement a local pilot. So, example in Valencia, but also in Rotterdam, where I live, and also in Ireland, where Professor Ian Carroll is leading the pilot. In the development, as I said, we do a co-design approach, and we develop a value-based integrated care framework. And I will come back to the value-based. I will try to explain it. But very special is to combine the development in direct discussion and interaction with the users, not only professionals, but also the older people and their families, and then implement it in so many countries. The purpose is that our experience make it possible to scale up the findings from this project. So what is value-based healthcare? So the aim is to reach the best citizen health outcome. But who knows what is the best citizen health outcome? It is the citizens themselves who know best. So professionals, I'm a professional. I try to understand the needs of the citizens, of the older people, but we need to talk with them and to find out what they need. Value-based healthcare means that we want to increase the value of the citizens. So not only cure the disease or make biochemical measures better, lower the blood pressure, for example. We ask the older people or the citizens or the patients, we ask them what is important. You have a certain condition, you have a certain situation. What do you want to improve? The care that we give to you, what elements do you want to improve? The development of this instrument is being done in collaboration with representatives of patients and older people, together with the professionals. They talk in small groups about what is most important, what are the most important goals by the care for the patient. And once we find this out, we translate this into a measurement instrument, a questionnaire, which we can apply in the daily care. So the goal is that we start the intake at the integrated care, or at some point we discuss with the patient with the help of a questionnaire what is the situation of this patient and what are the goals, and then we monitor the goals during the care process. So in value-based healthcare, we measure the health outcomes that are important to the patient, for example, quality of life. And this is one of the indicators while monitoring the care progress. So patient engagement is important because we want the patient or the citizen to have a freedom to control their own health. So this is an extra element in the care process, in addition to the knowledge of the healthcare professional or the social care professional. Professor Ian Carroll will go more in depth about integrated care. So integrated care is more than only health. It is also the social elements, but Professor Carroll will discuss this later. So we have 7 pilots in the VALUECARE project, and Valencia is one of these 7 pilots. Valencia is a city very much engaged in health innovation and collaboration between the university, social care, healthcare, and the municipality of Valencia. So we know the initiatives in Valencia from many European projects, and they are very inspiring to myself in the Netherlands, but also in other European projects. So we are very happy that Valencia is one of the main partners in the VALUECARE project. So the health and social care partners in Valencia, but also the city and the university, and also the expert consultants and the experts based in Valencia. So thank you very much, Elena, for letting me make this introduction. I don't know if there's any time for some question at this moment. Otherwise, because I have a class starting at 10 o'clock, so I cannot join after 10 o'clock, but I'm very happy to discuss with you later on. Thank you very much.
Okay, thank you, Hein. Thank you very much for your presentation and your words about Valencia. You have to leave. Don't worry if there are any questions, we will send them to you, okay, by email, so that you can contact with the public interested in knowing more about what you have presented. So thank you, Hein. We see soon, very soon, value-based consortium meetings. So thanks again. And now we move to Onia Carroll, okay, which we start the next block of the webinar with her. She is Professor of Healthcare Integration and Improvement at University College of Dublin in Ireland, and she's a consultant on rehabilitation medicine at the National Rehabilitation Hospital in Dublin. She's Secretary and Vice Chair of the International Foundation for Integrated Care, IFE. Guidance and training on improvement and change to leaders of healthcare systems across the world, establishing integrated care programs for older persons, chronic diseases, children's health and patient flow. So Onia, thank you very much for sharing this presentation with us, and you can start when you want. Let's see if everything works.
Well, I'll just share my screen. Yeah. Now, hopefully you can see that.
Okay, perfect.
Great, thank you. And Elena, thank you very much for the very kind invitation for me to be on the webinar this morning to share my thoughts about theory, concepts and definitions of integrated care, which is a huge topic to cover in 15 minutes, but I will do my very best. And just before I forget, tomorrow is our National Day, so I would like to wish you all Lá Féile Pádraig, happy St. Patrick's Day for tomorrow. So, as Hein indicated and as Elena indicated, really over the last 10 years, I have been a little bit obsessed with integrated care, the how, the why, and I have been involved in quite a number of local, regional, national and international initiatives trying to understand integrated care. So I have been a designer, an implementer, an evaluator of a wide variety of integrated care initiatives. And I'm very happy to share those thoughts with you this morning. So I think it's useful just to reflect as a global family who are interested in integrated care on why we need to do things differently. So this is a slide from the WHO and my friend and colleague, Nuria Toro. And these are issues all of us around the world can look at this slide and we can feel that it talks to our health and care systems. We are all struggling with emerging demands and system constraints. So I think it is, if you think about the need for us all to come together with all our different perspectives, I absolutely believe that we can get further faster by working together. And if we look at the types of initiatives that are being used to improve health and care, here is a slide. Now this slide finishes in 2007, but a more recent review of the different improvement initiatives really shows a very similar picture. Lean Six Sigma and at the moment agile initiatives. So these are very industrial, linear reductionist approaches to health and care at a time when we need to be thinking very differently about health and care, which is well recognized as a complex adaptive system. So As Einstein said, insanity is doing the same thing over and over again and expecting different results. So why are we persisting with linear reductions thinking when health and care is a complex system? And I'm going to quote Einstein again. A new type of thinking is essential if mankind is to survive and move towards higher levels. So I believe that as designers, as innovators, as healthcare practitioners, as individuals who are interested in the delivery, the design and delivery of innovation in health and care, that really we are beholden to come together to come up with really innovative solutions. And I think it's very important to realize that we all have very different perspectives on what we want or what we understand by integrated care. So this is a slide that I use when I'm coaching or when I'm teaching medical students or health and social care professionals. So when you look at this picture, what do you see? So normally I would be able to hear what your thoughts are, and we obviously can't do that today. But when I look at that picture, I see a fox's head, or I see a pelvis. And I would see a pelvis because I'm a rehabilitation physician. But my point in showing you this slide is that we all have very different perspectives. And if we don't understand the perspectives that everybody brings to the table, then we're going to be challenged when it comes to implementation and successful implementation and spread of innovation and integrated care solutions. So perspective is really important. So when it comes to integrated care, does it really matter what we call it? Well, as Shakespeare said, what's in a name? That which we call a rose by any other name would smell as sweet. But actually it does matter. And I thought I would just touch on a little bit of etymology today. And my thanks to Dennis Kodner, who did this back in 2002. So the word integration stems from the Latin verb integer, that is to complete. And the adjective integrated means organic part of a whole or reunited parts of a whole. And it's mostly used to express the bringing together or merging of elements or components that were formerly separate. And there were two very interesting publications on the whole area of integrated care last year that again looked at this idea of unity and combination when thinking about integrated care. So I did a quick Google search yesterday, and when I looked at the number of definitions of integrated care, there were 398 million results. But interestingly, I checked again this morning and the number was down to 371 million. And when I checked a week ago, there was only 5 million. So I don't know what's happening in the world around integrated care, but something very major has clearly happened. Although what happened between yesterday and today that so many dropped off, I have no idea. But my point is that there are many, many different definitions of integrated care. And that's a problem. That is a real problem when we're trying to understand what works and why, when we're thinking about the design and the implementation and the evaluation of integrated care initiatives. So integration is a combination of processes, methods, and tools that facilitate integrated care. And integrated care results when the culmination of these processes directly benefit communities, patients, or service users. And it is by definition patient-centered and population-orientated. So you'll see a huge number of different publications that tend to use those two different terms interchangeably, but they're actually different things. And as Kodner quite rightly pointed out back in 2009, he referred to integrated care as a concept, is an imprecise hodgepodge. The meanings are as diverse as the numerous actors involved. And also he said that although it's increasingly recognized as a critical adjunct to healthcare delivery and patient management, it's a modern day Tower of Babel. So I keep going back to Kodner's publications because I wonder how much progress have we made since those seminal papers in 2002 and 2009. And I would have to say that we have not made a great deal of progress. So again, I come back to the idea that it's up to us to really think about these things very carefully and really come together to decide how best to design and deliver integrated care. And there are many typologies. So Lewis and colleagues back in 2010 used the typologies of organizational, functional, service, and clinical. But there are many different typologies. And the most recent was published last year in a paper by Singer and colleagues. And they refer to structural, functional, normative, interpersonal, and process. So there's many, many ways to look at this. But if you are an organization or a region or indeed a country looking at the design and delivery of integrated care initiatives, these are the things that you need to think about in your planning for the intervention that you are designing. So I'd like to share with you what we did in Ireland to get over the issue of agreeing on a definition. So we decided that we would ask our patients in the Patient Narrative Your Voice Matters project. And our patients in Ireland told us what they want from person-centred coordinated care in Ireland. Person-centred coordinated care provides me with access to and continuity in the services I need when and where I need them. It is underpinned by a comprehensive assessment of my life and my world, together with the information and support I need. It demonstrates respect for my preferences, building care around me and those involved in my care. And that has recently been published in the International Journal for Integrated Care. I believe that paper will give you much more information about how we went about coming up with the definitions, co-designing the definitions and the I statements. So that looks like a very kind of straightforward paragraph, but actually when you really look at that integrated care will provide me access to continuity in the services I need, when and where I need them, a comprehensive assessment of my life and my world, together with the information and support I need, that demonstrates respect for my preferences, building care around me and those involved in my care. So we're many different people from around the globe on this webinar this morning. When we look at that definition, how are we doing around the world? How many of us can say yes to each of those different items? And I believe that we will not have succeeded in the delivery of integrated care until we can say yes to every single one of those underlying statements. So when people ask me, but Anya, how will you know? I will know when we can say yes to each of those statements. And that's quite a challenge. So a number of years ago in the International Foundation for Integrated Care, which was set up to bring together all the different individuals and organizations who are interested in the development of integrated care, they came up with the 6 blocks. So understanding your ambition, creating an enabling environment, building common values and narrative, workforce development competencies, supporting people's empowerment and engagement, and financial models and incentives, assessment and evaluation. But more recently, especially last year with the advent of COVID, we decided that we would look again at those building blocks. And my colleagues in IFIC, Leo Lewis and Nueves, have come up with the 9 pillars. And the 9 pillars are shared values and vision, population health needs and local context, people as partners in health and care, resilient communities and new alliances, workforce capacity and capability, system-wide governance and leadership, digital solutions, aligned payment systems, and transparency of progress, results, and impact. And I think it's really important to realise, though, that these are not pillars that are 9 silos. I think it's really important to see these 9 pillars as a very dynamic, interacting pillars. And when you're thinking about your regional or your national or indeed international integrated care initiatives, it's really important to be thinking about all of these different areas. Very often when we're looking at integrated care, we have our favourite few of these that we look at, whereas actually we need to be looking at all of these areas. Now, it may be that in your region or in your country, that you have got strengths in some of these areas, but you can't disregard those areas because they must be looked at as part of a whole. So a real holistic approach to integrated care is required for successful integrated care. Now, there are a great many models, and the WHO have got a very helpful publication on the different models that I'm going to share with you a select few. So the Minkman model, I quite like. I like colours, and I like models that speak to the things that I think are important. And in the Minkman model, the evidence showed that you require long-term commitment, that you need to have a shared and collaborative approach, that it requires new skills to lead and manage networks, and also transparent entrepreneurship. So those different items speak to me of the need for us to be thinking about a complex adaptive system approach to integrated care. So we need an innovative space. We need to move from innovation to really testing those solutions in an adaptive space, and then being able to move those integrated care solutions to operational space. And those three spaces need to be working together in a dynamic manner if we are to be successful. So then there is the Scirocco integrated care maturity model. And again, I really like this. And many of you will be familiar with this. It covers 12 different dimensions, and it's a really good way of having a conversation, either locally, regionally, or nationally, about where you are from an integrated care point of view. And here is an example. So you'll get a spider diagram, and what can happen is that managers will have a different view from healthcare professionals. Healthcare professionals will have a different view from patients and carers. So it's a really good way to start a conversation. But there are other tools. There's the Project Integrate framework, and we use this in Ireland very successfully to get a sense of where lots of different people felt that we were from an integrated care point of view. And there is also Pim Valentine's rainbow model. And again, I love this because it's colourful, and also it's very easy. There's a very nice infographic, so people can understand the different domains quite easily. And then there are frameworks to support integrated care implementation. So for example, there's the House of Care. There is the framework on integrated people-centred care, and more recently, there is the NAS framework, specifically looking at the adoption or non-adoption of technology for supporting integrated care. And in Ireland, we developed and we used the 10-step integrated care framework for older persons. So there was a lot of social science behind the development of this 10-step framework, and we have used that very successfully in Ireland. And there are many other tools. So for example, with the Shafea in Europe, they have the Integrated Care Performance Assessment. And indeed, there is SCIE, which has got wonderful resources, and the link is there for you to have a look at. And then from a digital point of view, of course, as my colleague Leo Lewis would say, digital is the glue and the grease. And yet, very often we find that, and especially with Trish Greenhalgh's work in the NAS framework, the digital solutions don't get adopted or scaled or spread. So it's really important that as individuals and organisations who are interested in successful integrated care, that we really seek to understand why we are challenged and what are the things that we need to do to overcome these barriers. What are the enablers? And I believe that it really is by bringing the right people together to be able to be creative and innovative together. So in summary, integrated care is not a goal in itself. It's rather a precious tool when it addresses complex care needs. It is multidimensional and almost as complex as the needs of those to whom it is provided. The transition to integrated care is a complex process with high complexity being present in all aspects. Integrated care models can be introduced with different goals in mind, and it can be seen as both a design principle and a means to achieve person-centred, efficient and safe care. Measuring integration is different from measuring the performance of integrated care, and very often you will see initiatives around the world who seem to conflate the two things, but they're actually very different. And I would say that in our experience, and in many different countries' experience, there is no single right approach that would be applicable and valid for every system. It's really important to think about evaluation at the start of any initiative. And indeed, 10% of the whole project cost should be set aside for evaluation. There's really interesting developments in the literature around how we should be thinking about evaluation. So instead of just thinking about summative, we should be thinking about developmental and indeed formative evaluation. And there are really interesting methodological approaches that can be taken. Indicators and trends need to be interpreted carefully. So, for example, there were reports that came out in the United Kingdom basically saying that integrated care had failed, whereas actually when you went back and looked at the aims of the projects in the first place, what they were judged on was not what the aim of the project in the first place. Information is the glue and grease to enable care to be integrated. And I think that's a real challenge for us in projects like VALUECARE. And what I would say is that we have done a lot, there is much done, but we have much more to do. So thank you. It has been a very great pleasure to speak with you this morning, and I'd be very happy to take any questions. Thank you very much.
Thank you, Onia. It has been very interesting, this overview on tools, models, frameworks. It's been very, very useful. Thank you. I'm sure there will be some questions afterwards in the slot. So we thank you, Onia, and we move now to next panelist, Borja Arrué from AIDS Platforms Europe. He will talk about user perspective of integrated care. And so Borja is Policy and Project Officer responsible for long-term care and elder abuse at AIDS Platform Europe, the European network of organizations, as you know, fighting for equality and dignity in older age. He monitors European policies in the area of care and brings the voices of AIDS network to relevant debates and consultations. He's involved in shaping a human rights agenda for aging, including human rights-based approach to care. He is also involved in several European-funded projects on care and new technologies. So, Borja, I see you are ready. We see the presentation, so the floor is yours. Thank you, Borja.
Thank you. Thank you very much. And let me thank VALUECARE for the invitation to join this workshop. It's a fantastic opportunity to learn about the project and also to share our views on this very important matter. So indeed, my presentation will be focusing on the user perspectives in integrated care. And I will seek to explain what's the approach we have in age to care and in particular to integrated care. Let me go to the next slide. Yeah, so AIDS Platform Europe, as you already heard, is the European network of 100 organizations, around 100 organizations working for older people or with older people to defend their rights in older age. We have a secretariat in Brussels. We are 14 colleagues based in our office in Brussels, and we get financial support from the European Union, which co-funds our work together with the fees we get from our network and our members. And the goal, as you heard, is defending equality and dignity in older age. That's the overarching goal of all the work we do in all different policy areas. So maybe I thought actually that the good way of starting the presentation is to actually ask all of you, each of you, to think about, to visualize a care user. So really to think about, who is a care user and to really try to picture that. When we do this exercise, when we talk about users of care, we often come up with ideas such as these ones, using medication, people that have to be in hospitals, or people that live in care homes and they get some training to kind of get back some abilities and functional abilities, let's say, that they may be seeing declining. So this is the usual traditional way we often look at care users. We usually think less of care users in these ways. So people in different life situations that are not the care settings we often think of. And actually, it's even probably more the case if I showed you this image of very dynamic and happy young people. Are they care users? Well, they actually may be care users. I'm actually pretty sure they are care users and they are accessing care at some point in their lives. If not, actually, yes, certainly earlier in the past, in their childhoods, and probably later in their lives. And probably at that very moment, they are also needing care. They also are care users. But no one would first think about them as care users. We could address other aspects of their lives, other characteristics of their lives before thinking actually about their care needs. So the challenge we see when it comes to older people is that we very much associate older people with their care needs, their social and healthcare needs. And that's an image that in a way has an impact on our perception of older age. We have a very medicalized way of looking at older people. We do not see other contributions, other aspects of other people's lives. We tend to reduce them and limit them to care needs, to being users of care, if you like. So we should always remember that needing care is actually one aspect of people's lives, and it's an aspect that is with us since the moment we are born to the moment of the end of our lives. So we are always users of care. That we need care, therefore, across our life course. And also, there is a last fact, and it's the fact that we should remain citizens at all stages in our lives. And there is no circumstance in life, such as needing care, that should put at risk our citizenship rights. So these are three kind of key reflections or principles that should be applying to all of us and should also be applying to older people in need of care. So that's something that I would like to remind before moving forward in the presentation. Some researchers have been putting forward a new idea of care, where actually we do not put the focus on the medical aspects or even on care as such, but we really focus on citizenship, on the full rights that we all have because we are citizens. So in a way, care and medical aspects come, if you like, as a support to our citizenship rights. And we should stop thinking of care as the end goal, as you could hear also in the previous presentation. So care is not the end goal. Care is one means that we have to actually be equals in society. And the main goal should be actually to ensure the citizenship of all of us and those rights and the aspects you see on the right are a bit like the end goal of should be the end goal of our systems and our care services. So in a way, what we witness in our advocacy as well, it's something we are adapting and we are changing and we are evolving with our members, is that we are moving from a focus on services and the needs. And that's something that even ourselves have been doing for some time. You know, it's important to say how services are organized, and it's important to talk about needs people have and how these needs are met or not by care systems. But we should probably need to be shifting towards an approach of goals and capacities. So actually, the ambition of services is not to just deliver services to people in whatever ways. Actually, the goal of services is to help people achieve their goals in life, to be involved in society, and to actually preserve and boost also their capacities. And this comes actually quite clearly when we ask our members. We were involved in another European Union project called Sustain. In that framework, we asked our members to share their views on integrated care and what's the role integrated care should be playing for them. Actually, they are confronted to many problems because of the lack of integrated care that make it quite clear that we have a problem in the way services are functioning. Because we put the focus on services, we actually forget that people should be at the center and that services should be organized in a way that people can enjoy their lives and really take care of other aspects of life other than their care needs. Silvio from Italy was reporting that when he was helping his mom with her care needs, actually they were going from doctor to doctor. They were witnessing how specialized care services were, but also how incapable they were to actually coordinate with each other and address the needs of his mom, and how they felt completely lost in the care systems and how different services were actually not sharing any kind of information. So they had a very bad experience of fragmented care. And Ingrid from Germany was telling us how in the case of her mom and mother-in-law, actually none of them knew what to do, how to arrange their care, and also what were the services available to them, and also what kind of financial support and state support they could access to afford those care needs. So these are two typical experiences of fragmentation of care. Experiences where people are still, let's say, blocked in this vision of the focus on services and the needs, rather than actually being able to access smoothly coordinated services that can help them focus on their goals and really boost their capacities and preserve them as well. with all the costs and all the the negative spillovers that were already mentioned in the previous presentation as well. So when we ask them, so what should be integrated care about, and what should help integrated care? How should people be helped by integrated care? Actually, the inputs we get are those you see in there. So it's the importance of focusing on people as people first, rather than patients. So not losing all your rights and all your dignity just because you have some care needs. So your role does not substitute whom you are. And it's also, about ensuring well-being. It's also about addressing social, cultural, emotional needs. And it's also about allowing people to remain active, to promoting autonomy and independence. These are usually goals that have not been that well addressed in care services, because we were focusing on the needs, on compensating for deficits. It's the kind of language we sometimes see in literature about care needs. Actually, we forget that it is also about preserving people's ability to remain integrated in their communities, to remain active, and to remain autonomous and independent. And that should be, we know that can be difficult in some situations, but that should be the ambition, the end goal towards which we should all be in a way, our aspirations should go in that direction. What can we say about COVID? COVID shows how bad can be the outcomes of a system that is based on the outdated ideas I was mentioning of the focus on care as the end goal, with providers not able to cooperate and work with each other. What we witnessed in care homes was a complete absence of conceiving systems as a one system where you have different components of health, social care, etc. But that should be smoothly coordinated, integrated, and also in a way, with coherent policies and funding that allows such cooperation and integration to happen. People living in care homes were often denied access to hospital care, even sometimes when free beds were available. That was the case in Belgium. The left image comes from a New York Times report in Belgium, and the other is from El País in Spain, where, well, the title reads that care homes were actually left abandoned when hospitals collapsed. So these two are the, let's say, the most serious and the most tragic images that show how bad our care systems are functioning and how necessary it is to work towards integrated care. Some people, very well-intentioned people in public debates, were asking to medicalize care homes and to medicalize care for older people. We would say rather that that's going backwards. Probably the solution is integrating services and ensuring that people can access the services they need in the moments they need. I will end referring to our current campaign in age. You may know that the United Nations are discussing every year the protection of the human rights in older age and the ability of older people to remain equals and remain integrated in society across the world. And currently we have this campaign to push the European Union and all our countries in the European Union to ratify a convention of the United Nations on the human rights of older people. We believe that actually this kind of UN convention, which is a binding instrument, can push states to revise their policies, and that also involves revising their care policies and their care systems. And we believe that if we really have a strong basis stating that we should all remain equal in dignity across our lives, including in older age, and a convention can help affirm that, then we will see a good change in policies, and we will also see a change in services. So I will stop here, and I will be happy to respond to any questions later on. Thank you.
Thank you, Borja. You have contributed to the debate and with a very interesting approach about the dignity, the right to care, and so on. And so I'm sure there will be some questions for you. And thank you, Borja. And now we move to next panelist and the last one before the short break. Okay. We have with us Oscar Mayora from Fundación Bruno Kessler. He is graduated in electronics and telecommunications, master's degree in computer science, and PhD in electronic engineering and informatics. He's currently head of the Digital Health Lab Unit at the Fundación Bruno Kessler Center and a scientific coordinator for joint research unit with the Trentino Local Health Trust and as part of Trentino Salute 4.0 initiative he will introduce now. And he has conducted research activity in the field of ubiquitous and pervasive health technologies. He has also participated and coordinated many international research projects in the digital health domain. And he's also responsible for the IPAJA Trentino reference site on active and healthy aging. So if you are ready, Oscar, the floor is yours.
Yes, thank you very much. Thank you very much. Thank you, Elena. So let me share my screen so I can show my presentation as well. Okay. Let me know if you see it. Can you see my presentation now?
Perfect, Oscar. Everything is fine.
Perfect. Well, thanks again for the invitation to our VALUECARE project meeting, and thanks for this invitation to our Valencia partners. So first of all, let me give a reflection on integrated care. Do we actually have integrated care in Europe? What do we mean with this? Very often, I think in all our let's say cities in our regions, we have the situation where every actor involved somehow in digital health or healthcare at large is playing their own direction. So what I mean is that very often we see policy going in one way, healthcare institutions in another, research in a different direction, companies, citizens. There is kind of a confusion sometimes in healthcare. So are we really going to the same direction, or everybody is pushing for their own agenda, right? So one thing that we did in Trento is that we tried to create a strategic view on healthcare provisioning. And on top of that, we thought that digital health is a way that we can use to promote actually this kind of common direction for healthcare provisioning. But there is no technology that can do any difference if it's not accompanied with an organizational hand, an organizational arm. So we believe that these two arms have to go in parallel and together, organizational aspects and technological aspects. So for this reason, we created what we call Trentino Salute 4.0, that is a competence center, putting together the different stakeholders involved in our region, okay? So basically, on the organizational side of Trentino Salute, and we share this as a good practice, I think, for other regions as well. What we believe is that we really need to put together on the same table and align the agendas of the main stakeholders. In one hand, the institutional planning from the policymakers. In another, we put the innovation digital health uptake of the healthcare provider in our region. On the other hand, we put the research and experimentation arm, let's say. So we have three main arms together as a governance of the digital health provisioning. And this is inclusive also for other stakeholders like, for example, the companies, like the industry, and also putting in the center the citizens. And what we mean by putting in the center the citizens is that they are active part on the development and the ideation and the design of all the integrated health new services that are available for them at the end of the day. So from the government's point of view, we created this, let's say, macro entity that can collect the input from everybody. Then from the technology side, we believe that we needed a platform that would be possible to integrate and to enable integration of the different health services and putting inside also the access for the citizens. So we are a small province in Italy. We have as a population near 500,000 people, But already the digital health ecosystem is being used by near 20% of them. So like 130,000 citizens are part of this ecosystem of digital health services. In this ecosystem, one important thing is that what we want to put on top of traditional e-health services like e-prescription or referrals or appointments or things that are already present in other places in Europe, other more advanced systems, let's say, kind of services. For example, services focusing on personalized medicine, services focusing on coaching as a digital tool for providing citizens with a better and easier way, in one hand, to conduct their own activities, and in the other, to alleviate the load of the healthcare professionals through technology. So other advanced systems, for example, relying on predictive models and data analytics and things like that. So it's not just the kind of common traditional e-health services, but this is advanced thanks to research in a way that is state-of-the-art top services being provided to the citizenship. This is, of course, integrating not only mainstream health data, but also data that is belonging and coming from the everyday, let's say, life of the citizens. So from the, for example, the world of the consumer electronics, the different wearable systems, and so on, in a way that we believe, in a holistic way, that all the data that reflect the life of a citizen are useful for better managing their own health. On top of that, one of our main aims is the one of working towards what we understand as digital therapeutics. So the possibility to provide actually applications and solutions coming from the digital world that can be equivalent to those coming from the clinical world, from the traditional medical world, in a way that digital technologies can become a kind of a medicine, really, and can help actually mitigating the problems of different diseases. So on this logic, we are implementing an approach that is called the app prescription paradigm. So in this case, for example, a clinician can actually prescribe a digital app in the same way as he would prescribe medicines to the citizenship. So really having the possibility that technology is empowered in a different way, in a new way, that I think in the very near future, we will see these kind of things coming around all around the place, all around Europe. For example, in Germany, there is already a legislation allowing actually to do prescription of digital assets for the citizenship. And this is a trend that I think is being pushing and coming more and more and more across our continent. Then another thing that is needed, and actually we incorporated, is in order to have really integrated care, is to open this kind of platform, of digital platform, to provide services in different contexts, for example, at work, for example, at school, for example, at the community level. So having the possibility to create these kind of open platforms in a way that other service providers could actually plug in and join to provide their own services and to interconnect with the mainstream healthcare in a way that data can flow more freely. And for doing this, we need, of course, the people be aware of it, and we need the consent of the citizens. So what we are doing is being done basically following a citizen science and implementation research approach, in which citizens are very aware about the data they have, the data they can share, and enable really this transformation from the digital world coming, all by respecting and by being compliant with all the different directives we have on privacy management, on ethics, but also on supporting the awareness really of the citizen that their involvement is fundamental for the integrated care intended in a model like this one. So where data can flow, where at the end of the day, the patient, the citizen, is the one getting all the benefits out of it. Okay, so they are part of the creation of the services, and then there is a way. This is the way in order to simplify the access actually to the different services. In our approach in Trentino, we have this going on going on in a very careful way. So we have an experimental platform and a production platform. They both are similar. They are actually twin platforms. And once something is mature at the experimentation level, when we do testing and training and so on of the different tools, then we can transfer very easily to the production. So in this way, we can go across the technology readiness level model from the very low layers to the very upper layers in a way that is safe for the citizen, having this kind of living lab approach. Just to conclude, because I don't want to take too much time, I just want to give an overview of what we are doing. Here is some list of kind of activities we do. In the left side of the slide, you can see this TREC environment, the TREC ecosystem, with a series of specific apps that could be, for example, prescribed. Some of them dealing with chronic diseases, others with, for example, the kind of diseases that we are facing now, like COVID, and other applications really working for supporting all the things that COVID, let's say, limit in this time. So, for example, due to mobility problems, we have to enable new services on tele services like pediatrics or things like that, oculistics that were not traditionally part of the digital health environment. We are now enabling through these kind of platforms. In the other hand, we are conducting a series of projects on different domains, and this is important. So R&D, for example, VALUECARE is a very good example, but also projects that deal with other aspects that are very important, like education, like technology transfer, and to other realities and other contexts, like, for example, Erasmus Plus projects or widening with Eastern countries and so on. So this is the end of my presentation. I wanted to provide you a kind of outline of things that have been done in Trentino as I repeat, as a kind of good example or a best practice that is being run in integrated care, introducing digital health as a way to support the integration. Thank you very much. And that's the end of my presentation.
Thank you, Oscar. It's very interesting what you're doing in Trento. So we are going for 5 minutes now. If there is any questions, I'm going to check at the chat. There was one question, but it was for Heinz, so we will send it to him about the difference between both concepts, high value care and value-based healthcare. So we will send it to him. And well, while I have one question, so I will put it to the panelists in general. So feel free to answer. So we have seen that healthcare, that integrated care, it has many benefits for the patient, for the people, especially for older adults. And what do you think? Why do you think that this is not yet a reality in all around Europe? Just has some concrete experiences in some countries or regions. And if you know about what the barriers or the enablers that you may identify, who wants to start doing so, answering?
Helena, I'm happy to start. Yeah. Okay. So the barriers and enablers, that's something that we have looked at using a variety of different techniques and methodologies in Ireland. But what was really interesting is that regardless of the methodology that we used, and when we compared our barriers and enablers with other countries' barriers and enablers, they're almost identical. So we are all struggling with the same issues. So in Ireland, our main challenges were around leadership and governance for the design and delivery of integrated care. The social and political context was also a big challenge. So our political masters have very short attention spans. And given that integrated care is really a long-term project, unfortunately, our politicians really aren't willing to give it the time that it really requires. Resources was an issue. So when we started our integrated care journey in Ireland, that was at the last recession. And it was a time when there was very severe cuts to the public services. But having said that, Elena, what was really interesting is that there was really significant creativity in that time of very scarce resources. So again, if you look at that from a complexity point of view, that need for tension is really important for creativity. Another issue was we have very big issues with the sharing of information. So we have different data systems that don't talk to each other across. So primary care has a system, community has got practically nothing, hospitals have got a different system. They don't talk to each other, so that's a big problem. And resistance to change. So people have got their own way of doing things, and they, as with anybody, we don't tend to like change. So looking at more enabling ways of facilitating change is really important. And then, but a key enabler, I would say, Elena, was our people. Our people want change. We've got, the expertise, the knowledge exists in our communities. And what we really need to do is to harness that creativity and work with the people that are going to be affected by those interventions. And I think that by working together and sharing that knowledge across countries, and by working together, we will get much further, much faster.
Thank you, Onia. Does any other? Thank you very much. You are right. Okay. And so, does anybody want to add something? Otherwise,
yeah,
Borja?
Elena. Yeah.
Okay, Borja.
Maybe I would just add the fact that what we see is that there is clearly an undervaluing of care in our society. So in general, people do not like thinking about long-term care services. Usually people don't like thinking about aging as a whole, and even much less about the need to receive care for everyday activities that we are, all of us, without any important functional abilities, doing without any problems. So there is clearly an undervaluing of care in our societies, and I would say rather social care than healthcare. And that means that the politicians policies have quite a modest level of ambition. Often this was the responsibility of the family, and it's still very much mainly the case in many European Union countries. So that's where we come from, and we are going in some direction, but it's very clear we are going in a direction of really improving quality, improving access, and better funding services. We have all the austerity-based rhetoric, which was mentioned, that hindered access of people to quality services. And we know that we are not spending enough in many EU countries on long-term care and care for older people. So, well, that's a discussion and a debate we need to have as a society, which is the role we give to social care, which is the funding we want to give to social care, knowing that, as I tried to say in my presentation, we will all need these services at some point, and that services should be allowing us to remain equal in society, which means raising the level of ambition of those services and the quality. So yeah, that's my take.
Okay, thank you. Well, I check if there is any question. Okay, no. So I think we can stop here for some minutes. Okay, so we are not that much far away from the initial schedule. So I think we can come back around at 10:50, okay? In 10 minutes, we come back in 10 minutes, okay? To go on with the webinar. Okay, see you later.
Now it is time to take longer strides. Time for a great new American enterprise.
This center is a part of the National Aeronautics and Space Administration.
This group also supervises research to advance the state of the art.
The ability to beyond the time.
When astronauts Stafford and Cernan systems look good.
Now it is time to take longer strides. Time for a great new American enterprise.
This center is a part of the National Aeronautics and Space Administration.
This group also supervises research to advance the state of the art.
The ability beyond the where the time.
When astronauts Stafford and Cernan systems look good.
Hello, good morning again. We are back with the second part of this webinar that will be devoted to case study presentations and concrete experiences on integrated care in the community. So we are going to start with an experience deployed in Barcelona, for the frail older adults, and Laura Pérez will present it. She is geriatrician, doctor of medicine, with training in epidemiology and biostatistics. She's currently clinical head of consultations and geriatric home care at the Intermediate Care Hospital, Parc Sanitari Pere Virgili. She leads the Plus Agile Barcelona project, which is the one she's going to present. And it is an innovative and ambitious care for frail older adults in the community, which has won different national awards. So go ahead, Laura, the floor is yours.
Thank you, Elena.
Let's see.
Yes, it's you're able to see. Okay, perfect.
Yes, everything fine. Go ahead.
Perfect. Thank you, Elena, for the presentation. As you said, the Agile Barcelona program is a community program of integrated care of older adults. Here is the outline of the presentation. As we already mentioned in the first session, frailty is a multidimensional clinical entity defined by the decline of physiological reserves and homeostasis that takes the person to a global function decline with a higher risk of falls, disability, institutionalization, and mortality. But what is important here is that it's a dynamic state that takes the person to a negative health event. And there is thousands of evidence in the scientific literature that says that frailty could be reversible, and what we need is multidimensional and interdisciplinary interventions. This is what we already know. Actually, here you can see like a summary of some interventions in community, not only international but locally here in Spain. For example, one developed in Valencia, also from Tarazona, Francisco Tarazona, also here in Barcelona in primary care by Romera and René Huguet. And the important thing is that all these interventions were funded, that they have really good results, but the interventions were really intense. For example, here Tarazona, they had in 65 minutes of exercise 5 times a week during 24 weeks. Or for example, Romera was exercise supervised by the physiotherapy 16 minutes 2 times a week, 12 weeks. And after the funding was over, this program were over also. That was our main concern when we developed the Agile Barcelona program. So the World Health Organization also said that we need to get further and to implement integrated care, to develop person, and this integrated care must be person-centered care according to the person needs. So how we can translate all this evidence into clinical practice was our main questions. So first of all, we developed a decalogue for implementation. We search in the bibliography and we find out this decalogue for the implementation of what we designed later on. First, we thought that the design must be a multi-component program designing a person-centered approach. Must be also flexible, have flexibility, for example, for the schedule of the persons, range of activities also that can be or were attractive for the other adults. We must empower the person and the caregivers, otherwise the program will not stay longer. The program must be designed in an evidence-based, but also be sustainable and contextualized intervention. We also said that we need to move the intervention close to the person, because at least in pediatrics, we are so used that the person came to the hospital, but maybe sometimes it's late. So we thought that the intervention should be close to the person, in this case, in primary care and community care. We need to build integrated care models. We were talking about this in the first sessions, and this is a really important point. We need to involve community agents to be this program sustainable. Use an opportunity case finding and recruitment strategy, because we are not able to see or to take care of all the adults. We need to promote user participation, co-design the program, otherwise it will not be maybe attractive for them, and raise awareness and sensibility in decision maker and policy maker agents. So what we thought, as I already said, we thought that we need to change how we understand the geriatric care. So we are also always used to wait for the patients or the older adults to come into the hospital, and as I already said, maybe it's too late. So we decide, okay, let's move to primary care and work together with primary care doctors, nurses, and social workers to see and work in a collaborative way and to see what happened. So how we designed the program is that the primary care team did the screening for all the other adults older than 80 years old with at least one risk factor: slow gait speed, memory loss complaint, involuntary weight loss, or social risk. We use the gerontopol Freight screening tool. We decide with the primary care teams that was the best screening tool for them, because it was short and was quick to apply. Is six questions. They ask you about if the person lives alone, if has been lost weight, if the gait speed is slow. And then you also have a question surprise, that if you think your patient is frail, you say yes, and then you should transfer this patient or ask for a geriatrician team evaluation. So the geriatric team, a geriatrician and a physiotherapist, work in the community in the community care center and perform a comprehensive geriatric assessment with the specific Freight tools as the short physical performance battery. Then together with the primary care team and the older adult and maybe the family, if it's the case, we tailor an intervention plan. We design an intervention plan, and then we follow them up at 3 months, and then the person will continue this follow-up with a community, with the existing community resources. So the tailored intervention plan can have three arms: the pharmacological intervention with review prescription, trying this prescription, treatment conciliation; then non-pharmacological intervention, health education, nutritional advice, personal empowerment through motivational interview, and dementia screening. Then the physical activity program is a 10-session, 1 hour per week, that includes strength, endurance, flexibility, dual task exercise, and of course socialization. And we start the past July 2016, one day a week, with the geriatric team. Me as a geriatrician and a physiotherapist went to the primary care center. And of course, last March, with the actual COVID pandemic, we had to, but the moment, stop the program. We recently published the result, the 3 years results, with 12 participants with a mean age of 80. They were quite independent. As you can see, the Bartel index was 95, the Lawton index was 6, and 42 lives alone. That's important because you also can see that almost 35% of our participants has at least one fall in the last year. They were living alone, but they were falling also. And they were frailty according to the short physical performance battery, and there was also a high percentage of vulnerable or frailty degree according to the clinical frailty scale. And the polypharmacy was also high with 7 drugs in the mean. So at these participants, we offered them physical activity in the 97%. We referred them to the dementia unit to almost the 17%. We performed health education in 95%, and we performed pharmacological changes in 56%. Interestingly, we changed psychoactive drugs in 30% of all of our population, and the results were really good. I mean, you can see here the results of in terms of physical performance in the short physical performance battery before and after, and there were clinical and statistical significant. As you know, a short physical performance battery under 10 is a frailty indicator. And you can see here that after the intervention, they are still frail, but they improve. And this is important because our population is a really frail one. And we also managed to improve the frailty. 21% improve the frailty degree according to the clinical frailty scale, and 64% stay and maintain their clinical frailty degree, but 14% have an impairment. And the results, if you remember the first this table that I presented in the first moment, our results are interesting because even if we offer less intensity of physical activity to the participants, our results are almost the same, and we have a quite good adherence. Almost 80% of our participants have more than 75% of adherence. We have also limitations. We are still working to assure the continuity of therapeutic exercise. Now we have an agreement with the Centro Civic, with the civil center near the primary care center. So we co-design with them a physical activity program according that can be suitable for our participants. So this is good, but we only did this with one civic center. We don't have a formal cognitive intervention, and as we have a 20% of cognitive impairment prevalence, that could be a good thing, but we do not have. We do not have yet a control group. And we are, as I will tell you, we are developing now a virtual way or a semi-presential way to perform our activity. We also have learned some lessons. We know that for this intervention, we have to be flexible, and we have to work in multidisciplinary team and integrate of care. These are the main key points of our intervention and the reasons why it's working. We think that ADIO Barcelona is a good example of collaboration and coordination between primary and geriatric care. It's innovative because it's a real-world implementation, multidimensional model of care. It's also an intervention person-centered care. That is, the intervention is tailored to the person's needs. So also, our intervention program does not rely on extra funding. It's also it's only a reorganization of the existing resources, so that the sustainable is assured. Our experience, we think that can be transferred or replicated, but it will need to adapt to the population need and the environmental characteristics. And what are our next steps? Before the COVID, the actual COVID pandemic, we were thinking. Actually, we get a grant and we get funded to do this to adapt the intervention to other primary care centers in Barcelona. But just start last January, the COVID pandemic we had to stop all our plans. So now we are trying to readapt what we were thinking and to transfer our intervention to a semi-presential intervention And we are doing a co-design session with the users and stakeholders to find out the best way to do it. So thank you very much for your attention. If you have any questions, I'm here.
Thank you very much, Laura. We like a lot your initiative. It has many things in common with the ones that our colleague Tamara will present later on. The VALUECARE in Valencia, and thank you very much for your presentation. And now we move to the next one, an experience that comes from France on integrated care and home care professionals. We will have two girls presenting it. Clotilde Berg, who is a social worker, a master's degree in local services management and in change management in structures. She's working as social innovation project manager for 11 years at Autonomous Lab, where she carries out collaborative actions and studies and leads working groups to bring out innovative solutions in health and autonomy for the older adults. And also Lucie Vamond. She is master's degree in European and International Law and in European Affairs. She's responsible for the coordination of European projects at Autonomous Lab and for the participation in several European networks. She has a wide experience in the management of European projects, and she's actually gathering experience on social innovation and specifically in co-design practices in order to tackle social needs in the domain and health and care for the older people. So who's going to start? Clotilde or Lucie?
Yeah, it's Lucie.
Oh, Lucie. Okay, thank you. So let's see.
Thank you very much, Elena, for this introduction. So we will start the presentation. Yeah, thank you very much. So,
perfect.
We are Autonomous Lab, so we are the future gerontopole of Nouvelle-Aquitaine. So we are a living lab in France focused on active, healthy aging. And today we have decided to speak about home care professionals or home helpers, as you want. So perhaps some introduction regarding the integrated care in France. So the next slide, please. Of course, there is a strong coordination of professionals in France who is helping to improve the quality of life of older people, not only regarding the health domain, but also on the social dimension. So the value-based integrated care is strongly developed through various tools in France, both at the national level, but also at the regional level. At the national level, we can find some different tools. The first one could be Maya, which is a tool which aims at learning how to work together in local sub-departmental territories, thanks to different meetings, regional directories, different places of exchanges, so that people can exchange together regarding integrated care. We have another interesting tool, which is called Spasad, which is a tool ensuring both home nursing services and home caregivers services. Another interesting experiment was PAERPA, which was an experiment aiming to set up a territorial action plan around the elderly people at risk and their loss of autonomy. And the last one could be the PTA, which is the Territorial Support Platform, which is emerging from the experimentation of Maya and also from PAERPA. And it is department measures for coordinating actors around the issues of prevention, support and care for the elderly at the social and health level. So this measure, of course, is rather intended to professionals and caregivers and not for the patient directly. So at the regional level, we can say that we have also other different tools, such as calls for proposals, and as in many countries of the European Union. But we have also an interesting tool, which is a digital one, which is called PACO Globule, for the coordination and the interconnection between professionals, such as doctors, nurses, pharmacists, and so on, also which are located in distant territories and who are working on personal health data, also to identify more quickly diseases of immunological origins, which could be chronicals such as diabetes, asthma, polyarthritis, and so on. So PACO Globule eases and secures the patient journey, as we call it here in France, and secures also the home care through agenda sharing, for example, but also sharing of pictures, messages, appointments, common appointments, and so on. So to summarize this very rapid introduction on integrated care in France, we have different initiatives to push coordination between professionals at different levels, health and social, and it is strongly encouraged in France by our public authorities. However, and in order to help improving the quality of life of the elderly, we have a specific valuable-based integrated care which is currently being supported, which is the recognition between professionals and the recognition of specific jobs, such as home care professionals. We already spoke about that just before, and this thematic is really important to increase the well-being of home care professionals and enhance their quality of life at work, and therefore the quality of care and health of the elderly. But I will let Clotilde, my colleague, talk about those specific initiatives regarding care helpers. So Clotilde, the floor is yours.
Thank you very much. So this
Clotilde, we don't hear you.
Okay, sorry.
Okay, now.
It's okay?
Okay,
Great.
it's okay.
Sorry. So this is a different national and regional tools to try to join health and social. But there is some barriers which constrain this coordination, notably cultural, financial, and organizational issues. For example, often professionals don't want to share information because they misunderstand other professionals, their mission, their constraints. We have also home helpers who don't consider themselves and their information valuable. They don't dare sharing their point of view, notably when they detect frailty at the first professional of daily life of all our disabled people. We have also some organizations which don't organize the report and the sharing of beneficiary needs to other professionals because of a lack of time, a lack of recognition to the home health sector. And the lack of attractivity of home helper sector constrain employers to train regularly the new employees to a lot of thematics, and they have a lack of time to train to the goals and tools of integrated care. So to answer this challenge, Autonomous Labs has taken the hypothesis that improving quality of home helpers paths will improve the quality of beneficiary services. So on 2014, we launched an action study based on the identification of areas of tensions in the careers of these professionals. So from the communication that was made around these jobs to the condition of recruitment and integration, to the modalities of training before or during employment, or by looking at the modalities of coordination between professionals, and lastly, the professional evolution. After sharing these results of this study, we drive some co-design meeting with the actors and define some innovative solution aimed at acting on the levers in favor of attractiveness of these professions, of their professionalization, as well as the retention of employment via managerial and organizational innovations. So I'm going to hurry on some solutions that Autonomous Lab developed, but we will send you the PowerPoint with some English information, but the time is short. So I would like to detail you the last project, which is a training program for managers on different managerial approaches. Because for us, it's really important to support the managers in new managerial, organizational, and economic innovation in the framework of home helper services. The aim is to give greater recognition to the expertise of home helpers by giving them more power to act, more space for initiatives, notably to co-create solutions directly related to their work. Because home helpers have the expertise of the field. They know often better than managers, which may or may not work with beneficiaries or in link with other professionals. So we put the purpose following. The first is raise awareness of managers on new organizational, managerial, and economic methods of works. And the second is to train mature structures in the implementation of these new approaches. What for is to change and advance the current model of home helpers towards greater sustainability. So this program is built upon 4 steps. The first is a raising step to develop the awareness of managers to different managerial approaches, because we didn't want to choose in place of the director, which should stay the leader of this change, often in changing himself. So this choice should be guided by his conviction, his personality, his organization, and its history. The second step is a maturity diagnosis aimed at studying the gap between the manager's project and current practices as perceived by the actors in the structure. Then a training step on one of the different approaches, first in a collective training and then in an in-depth infrastructure training session. This program is spread over 2.5 years, and we are conducting research to measure the impact of these different approaches to the different stakeholders. So we chose six different approaches: the shared governance, the lean management, management by quality of life at work, the Buurtzorg approach, the Montessori approach, and a plural approach. And we support managers on the 6 different approaches. So currently, after the awareness of 19 directors of home helpers organization, 14 of them continue the adventure today. And these organizations are representatives of the sectors with different legal status, public, profit, or non-profit organizations, with different size and working on different types of territories. The first feedback from professionals is extremely positive. For the manager, at first, we appreciate to discover new way to manage more human, but also for the professional in the field who have the impression of moving from being pawns to being actors, it's a quotation, and with a feeling of being taken into consideration, recognized for their skills, and no longer executing them. The first company in France, called À l'Envie, which have implemented these organization models, reports very positive effects in terms of quality of work, with fewer sick days and accident at work, but also with professionals declaring that they have regained a sense of meaning and motivation at work. And for beneficiaries who lastly feel better served by these professionals. In conclusion, currently integrated care is one of the goals in France, but some steps are still necessary before reaching this goal, notably work on cultural, financial, and organizational barriers. Our explanation was just one part of the whole problem in order to tackle correctly the integrated care in France. Thank you for your attention.
Thank you very much, Clotilde, very interesting. And now we move to the next panelist, Tamara Alhambra. She will present the integrated care model for our VALUECARE pilot in Valencia. She is a researcher, university lecturer, and science communicator. Bachelor degree in psychology, also master's degree and advanced in research and treatment of psychopathology and health, and master's degree in general health psychology, and also a PhD in psychology research. Her research activity focuses on health promotion, self-care, and improving the quality of life of specific populations such as older people, chronically ill, cancer patients, and vulnerable populations. This work is carried out at the Bienestar Research Institute of University of Valencia, where she works as researcher and manager of European-funded projects. So, Tamara, you can start. The floor is yours.
I hope you can hear me.
Hear and see the presentation perfectly.
Okay, perfect. So I'm going to present the integrated care model of the VALUECARE pilot in Valencia. First of all, I would like to briefly introduce the VALUECARE project, which has been already mentioned by Heinrad at the beginning of this webinar. So the VALUECARE project is a project funded under the Horizon 2020 program from the European Commission. And the vision of this project on healthy aging is that any older individual in society can live the best life possible according to what they value. And this can also be facilitated by access to high quality, person-centered, evidence-based and affordable health and social care services, which can also be supported by strong and integrated health and social services. So that's our vision from the project on what healthy aging can be. ValueCare partners also believe that taking an enhanced value-based approach, including not only health, but also social aspects and aspects on lifestyle, and this approach also supported by a secure and robust digital technologies will help to achieve this vision of healthy aging. The aim of this project is to deliver an efficient outcome-based integrated care to older people, including these both aspects, health and social care. Facing and the target population in the project will be older adults facing cognitive impairment, frailty or multiple chronic health conditions. And the ultimate goal is to improve the quality of life and also their families, their caregivers' quality of lives, as well as to promote the sustainability of the health and social care systems in Europe.
Excuse me, Tamara, do you know that your presentation is not moving?
Yeah,
you are still in the first one? Oh, okay.
In the first slide?
In the first one, yes.
I don't know why. Now it's moving?
No.
Okay. Let me check. But can you see now the presentation?
No, we see you.
Okay, sorry.
Okay, we see the presentation
now.
Yes, perfect.
The second slide.
Yes.
Okay.
Yes, the ValueCare project.
Okay, so this project is based on the value-based health and social care approach, and ValueCare will develop in the frame of the project a robust, a secure, and a scalable digital solution to integrate both health and social care, and to conduct also efficient outcome-based delivery of integrated care solutions to older people in 7 large-scale pilots in Europe. And one of these pilots, it will be in Valencia, in Spain. It is about what we are talking about in this presentation. So in Spain, the pilot will be conducted in Valencia. It's one of the biggest cities in Spain, together with Madrid and Barcelona. And in particular, the city of Valencia, which is located in the east part of the country, has a population over, the city of Valencia has a population over 800,000 inhabitants, of which more than 160 are older adults, that's plus 65, and a percentage of 76 are women of these older adults. And how is the care provision in the context of Valencia? Well, social care and healthcare are fragmented, as happens in most countries. So the public health care is provided by the regional government, and the public social care services depend mainly of the municipality. And also some additional services, such as the teleassistance or the home care service, are provided by NGOs or third parties paid by the city council. This lack of integration, not only between the health and social care services, but also between data and information that these health care and social services share. So this hinders the provision for a more efficient intervention from a holistic approach, which we have mentioned in several presentations so far during this webinar. So in the ValueCare pilot in Valencia, the stakeholders involved are the primary healthcare centers, the municipal social services center, informal caregivers, and participants, who are older adults.
And we have different partners involved in this project. One of them is Las Naves, the organizer of this event on the behalf of the municipality. They will lead the pilot and will also engage the different key stakeholders at local level. Then the other organization involved as a partner is Polybienestar Research Institute from the University of Valencia, which I am representing. And we are engaged in both the co-design phase of the project, in which the interventions and the needs of the older adults are consensus and also co-designed together with the participants and their caregivers, and also in the implementation of the pilot. The third party involved is the third organization involved is Cabeloce, is the leader of the implementation of the co-design activities in this pilot, and it will also support the implementation and the evaluation. And we have also different supporting organizations which are not partners but are really key stakeholders within the pilot, which are the Clinic Hospital in Valencia, which has already involved 6 or more now healthcare centers in order to recruit and also to assess the needs of the older population, and also the Valencia City Council. Sorry. Who are our target population? Our target population are frail older adults with mild to moderate frailty. And the aim of the Valencia pilot is to provide an holistic approach, an integrated care approach to frailty, encompassing physical, psychological, and social aspects. That means that frailty will be understood as a biopsychosocial condition. And the description of this pilot will be based on a tailored and individualized care plan for each person. And this care plan will be supported by a technical solution, which Hein has already mentioned, and also Oscar, and by the support of the social and health professionals involved in the pilot. The duration of the pilot will be 12 months, in which we will conduct a baseline evaluation at the beginning of the intervention and a follow-up measure after 12 months. This is a pilot flow chart in which I will present the different steps. I have to mention here that this project, in comparison with the other project or research that has been presented in this webinar, is in an early stage. We are still designing how the pilot or how the care pathways intervention will be, and we are working also in the design of the digital solution. So this flow chart is what we are expecting to get as part of the intervention or the path towards the intervention. And then I will present you one of the care pathways, which we have a more advanced design so far. So we will start with the identification of the potential participants and the screening of frailty of these potential participants. We will do that identifying frail older adults at the healthcare center. So for that, we have involved several healthcare centers and GPs and nurses who will be responsible for identifying from their patient quota the potential participants in the VALUECARE project. Those meeting the inclusion criteria, which are having more than 65 years, not having any cognitive impairment, and having frailty, and also those showing interest in participating in the VALUECARE project, will be screened using the frail scale in order to know if they suffer from frailty or not, in which part of the frailty spectrum they are. Then we will conduct a baseline evaluation among those older adults screened as frail, and we will assign those participants. We are still working on if we will randomize or we will do it by assignment to an intervention or to a comparison group. And after signing the informed consent and the baseline evaluation will be performed.
We will include as part of this baseline evaluation the VALUECARE agreed measures, which are based in the ICOM set measures, and also a frailty evaluation from a biopsychosocial approach, which will be based on the Tilburg Frailty Index, which measures not only physical aspects of frailty following the Freud criteria, but also psychological and social aspects of frailty. Also, caregivers and professionals will be assessed. For example, the burden of the caregivers will be assessed in order to know if after the intervention we have provided them with an increase in their quality of life. Then, after this baseline assessment, we will start the process of the care management, in which healthcare professionals, psychologists, and social workers will decide on the most appropriate care pathways for each participant based on this baseline evaluation of their needs. And from that, we will prepare or we will tailor to each participant an individualized care plan. This individualized care plan will be presented through a technological solution, through a digital solution. So each participant will have a tablet in which their individualized care plan, their goals, monthly goals, weekly goals, will be presented. And the intervention, as previously said, it's aimed to tackle the biopsychosocial frailty. For that, we have designed, or we are in the process of designing, different care pathways. One more based on the physical frailty, and that will include a care pathway on physical exercise, one care pathway on nutrition, and the adherence to medication, and one based on the psychosocial aspects of frailty, which I will explain in more detail in the next slide. So this digital solution will not be only accessed by participants, by older adults, but also the caregivers and the professionals involved in the project will have access to this individualized plan in order to monitor the progress towards the set goals. So in this slide, I am briefly introducing the psychosocial care pathway, which is based in two instruments. One is the digital solution, which we have already briefly presented, and the other is the motivational interview, which will be used as a tool for setting the goals and getting ready also. Through the motivational interview, which will be conducted by a psychologist or social worker together with the participant. From this motivational interview, we aim to detect participant psychosocial needs and preferences, to identify in which stage of change of the transtheoretical model of Prochaska y Di Clemente the participant is, if it's ready to change, if it's in action state, so it's taking action in order to accomplish that goal, or if it's still not ready and we need to work to get him or her ready. Also, through the motivational interview, we will resolve the ambivalence or resistance to change by promoting, through motivation, helping the participants to explore and resolve this ambivalence about the unhealthy or not satisfactory behavior or habit. And also to establish together with the participants, through a professional participant collaborative process, the goals to be achieved in the process of change toward the desirable behavior, in order to cover their needs and preferences that have been already identified through this motivational interview. That won't be only a session, it will be several sessions working together with the participants, and we will review it and we will go through the motivational interview and through a revision of the needs and preferences in a monthly basis. And for the VALUECARE digital solution, this will provide the place in which the participant's goal will be set. So the participants, together with the professionals and the caregiver, will have access to these goals through the digital solution. Professionals will monitor participants' progress towards the goals, and monthly follow-up calls to adjust or change goals will be when achieved or when adjustment is needed, will be conducted in order to follow up closely each individual. Which are the expected results from this pilot? So at project level, the ValueCare project aims to design and deliver this personalized integrated care service tailored to individual needs, moving from a traditional care delivery to an integrated care outcome-based delivery model. Also, one of the most ambitious goals is to provide a secure, scalable, and robust digital solution for integrated care to achieve better outcomes for citizens, specifically for older adults, to improve also the care experience of participants and their families, having this closely monitored from health professionals and social care professionals, and to improve the efficiency in the use of resources and the coordination of care. And in particular, in the ValueCare pilot in Valencia, we aim to improve participant health outcomes in regard to frailty. In terms of physical activity, that physical activity care pathway will be aimed to reduce physical frailty, physical limitation, walking problems, and risk of falls. In terms of nutrition, to maintain, achieve an optimal body mass index, and also to improve the dietary intake with higher percentage of protein, and also following the Harvard plate. And in terms of medication, the adherence to medication care pathway, it's aimed to improve the adherence to medication and the follow-up of medication risk problems in case they have polypharmacy or there is some interaction between different medications. And in terms of psychosocial aspects, that's about the pathway that I have explained, we will expect a reduction of the psychosocial frailty, loneliness, and improvement of the quality of life. So that's all for me. If you have any questions, I will be happy to respond them.
Thank you very much, Tamara. That reminds me that we still have a huge work in front of us for the next years. Thank you, Tamara. Okay, so we go to the last intervention today. It's an integrated care and the medication scheme with my Flemish, it's full als tip op scheme, okay, by Elise van Opstal, who is coordinator of healthcare policies in the city of Hals. And as coordinator, she initiates and coordinates regional user-centered innovation projects in care, develops collaboration strategies with actors in healthcare, and she's also responsible for the local care living lab, which organizes events, workshops in healthcare and supports innovative solutions of businesses with co-creation and real-life testing. I would like to add that Elise, unfortunately, is not live today at the webinar, so if there are any questions for her, we will be happy to email them to her and get back to you. Okay, so we can start with Elise's presentation. Hello again. We are sorry, but we have some technical problems with the video from Elise, which is a pity because it was really an interesting project. But anyway, we will try to, in some way, to do the communication and to share this video anyway with you. Okay, and just now we have some questions concrete from the public, and we have to go ahead with the webinar. We have 2 questions for Laura. Okay, from the Agile project, from the public, okay, and it is that process of integration means a huge exchange of information. How are you going to cover the issues about big data and data protection? And in the same line, how do you manage consent forms with people under dementia?
I start for the end. With people with dementia is the caregiver who signed the informed consent. Then regarding the big data, we don't have a solution yet because we are just working in the in one primary care center. Our plan is to scale up our program to 3 primary care centers here in Barcelona. But is as you see in the presentation, after 3 years we were able to involve only 120 more or less participants, because we only go to the primary care center 1 day a week, so we don't have a solution for the big data management.
Okay, thank you. So maybe for the scaling up. And the last question goes to Clotilde or Lucy. Okay, home helpers include home caring professional services or just from relatives? Informal caregivers.
So home helpers is for us the professionals who intervenes at home in the daily task, in the support people at home in the daily activities. So that is professionals.
Okay, thank you. Okay, well, I will have one. Okay, for instance, for your initiatives, okay, to be scaled up, what do you think will be this possible? What enablers can you identify to continue and extend your experiences? That will be maybe for Laura and Lucy or Clotilde. Because VALUECARE is still in the first stage, so.
Sorry, can you repeat, please?
Yes, sure. Yes, what enablers do you identify that would be possible to continue and extend your experiences?
If I can go first, for us, as we are already trying to scale up our program, we are trying to connect with all the community resources. We are trying to map all the community resources in the primary care areas, and to build boundaries, to build alliance there with these resources. I mean, civic centers, casals, neighborhood organizations or associations. Also, for example, the radars program, because what we are trying to do is not only is to assure a continuity of the program. We don't want to keep the patients with inside the Agile program and to have them all the time. We want them we want to empower them to continue doing physical activity to improve their health.
Okay, thank you. That's clear.
And maybe for us, our program, I may know, lasts till 1.5 years, and we are doing a research. We are conducting a research, so we are waiting for the results. But already we know that we are involved on 6 departments. 14 home helpers organizations come from 6 different departments of France, and we are solicited by regional level to do the same experiments with retreatment establishment for elderly people, and so we will reflect to this the way to develop this program for also retreatment organization.
Okay, thank you. So we don't have more questions. We just broke all the time schedule. So I just want to do a little bit short summary of what we have been, and we will close the webinar. Okay. So in the first part, we have seen an introduction to value-based healthcare, to integrated care, and also to the value-based project. With ONIA, we have seen a wide range of models, frameworks, and tools for implementation and evaluation of integrated care. Also the lessons learned from evidence. With Borja and Age platform, they had introduced the approach of the right to care, the care as a key part of the system of life, and that there is an urgent need to be addressed, cares as a key policy priority on the public agenda. Okay. Also with Oscar Mayora, we have seen the possibilities that the right coordination among stakeholders on an innovation ecosystem and the potential that the ICTs have to support integrated care experiences to benefit all parts of the health system. We have known about barriers and enablers to extend integrated care in organizations. We have also learned about concrete experiences all around Europe. One experience applied of integrated care applied to frailty, another one applied to improve care professionals' development and health. Also, we have known all the initiatives at national, regional level going on in France around integrated care. We have known about the VALUECARE pilot that will be implemented in Valencia, and our new conception of the combining social, health, and psychological aspects for the care to older people. And also we started to learn about the medication scheme from us, and we will see how we can solve these technical issues so that it is part of the webinar, okay, to be extended afterwards. And so I just have to say that thank you very much to all the panelists and also to the public that has been with us during the whole morning, especially for adjusting to time. This has been very interesting content. We have learned a lot. I'm sure that the public will have learned a lot as well. And I hope that this is the beginning of a good friendship and collaborations for the future, because I think we can deepen on our connections, and we can learn deeper and further from the others. Okay, so thank you very much. Thank you to the public, and we hope to see you soon somewhere else. Okay, thank you very much.